We found one, and he canceled. But he gave me his talk, so I will do my best to explain the different problem that can arise with minimal invasive. So I will start with this. So this is one of our anesthesiologists in Paris, and I will try to describe the anesthesia management in robotic cardiac surgery, but some of the things can apply also in minimal invasive. And I will speak about both coronaries and mitral valve because there are a lot of differences. So there are some major difference in terms of selection of patient for robotic cardiac surgery. And the first thing is, of course, you have to be able to ventilate on one or two lungs, and that implies that the patient should have probably no pulmonary disease or minimal pulmonary disease. So pulmonary function tests are very important in this patient. When you do a harvesting of the memory artery totally endoscopically, you have to give CO2, and that decreases the pressure, the preload, and therefore you can have both decreased cardiac output and ventilatory status with hemodynamic consequences. Also, we have to deal with myocardial ischemia because some of these patients are done on beating heart if you have a program with beating heart, and therefore you have to occlude the coronary, so you have to be prepared to place a shunt in case you have ischemia, and then we'll discuss about postoperative management. So for us, again, the selection is very, very important. The first thing we exclude is any thoracic or pulmonary diseases like COPD, asthma, emphysema, and we are very enthusiastic about CT scan. We do CT scan of the chest in a lot of patients to make sure that they don't have any contraindication. For example, here we had a patient that had no comorbidity in terms of pulmonary problem, and this was a young patient who had tricuspid valve replaced. It was his second time, and during the operation he developed intrapulmonary bleeding during the extracorporeal circulation, and we almost had to give bronchial blocker in order to stop the bleeding. And it turned out that this patient had an anomaly of of one of the vein of the pulmonary system, which we hadn't seen because we had not done prior CT scan. I know it's very rare, but these are some of the complications that can arise. Some of the other problems we had were major post-op pulmonary atelectasis after CABG. So what we tend to do in anesthesia is every half hour the patient is being ventilated on two lungs, and this seems to decrease the amount of atelectasis. Also, one thing that you can tell your anesthesiologist in terms of unilung ventilation, instead of that, you can decrease the tidal volume, continue on two-lung ventilation with a small tidal volume in order to ventilate the patient. Because one of the problems when you exclude the lung for a long time is atelectasis, and then in the post-op period the patient will have some kind of hypoxia. We also had a patient with a previous mediastinal irradiation, and that can be a problem because, as you know, there's no real good test for measuring the ventilation, the exchange ventilation in patients that had irradiation. And even though your pulmonary function tests and your blood gas can be normal, some of these patients can be difficult to wean from the ventilator, especially if they had single lung ventilation. So you have to be very careful. If patient was irradiated, probably it's better to do a sternotomy. So again, we do pulmonary volume and flow tests in all these patients, arterial blood gases, and thoracic CT scan. Now, how do you, is there any different monitoring in this patient? Well, in our unit we use, of course, peripheral venous line, EKG, and a bispectral analysis. Bispectral analysis gives you the amount of anesthesia of the patient, and it has to be within a certain range. Why is this important? Because if your patient becomes hemodynamic unstable, As you know, it can be because he has too much anesthesia or not enough anesthesia. If you are sure with this bispectral analysis that the patient is in the right zone, then therefore it's not due to anesthesia but due to another problem, which can be cardiac or volume related. So we use continuous monitoring of cardiac index, and I will go into this in the next slide. And this is very important. Some of these patients, we use central venous oxygen saturation and stroke volume variation, and I will show you what this means. Of course, if you're going to use beating heart, you have to make sure your patient does not cool, because as you know, in the room it's sometimes 20 degrees, 19 degrees, so we use bear hugger in order to maintain the patient warm. Of course, when you do an operation with corporal circulation, this is not the same problem, because you can rewarm the patient. So this is what we add. This is a small apparatus which calculates continuously the cardiac index of the patient and the venous oxygen saturation. It's very simple. You connect it to a radial line, so in terms of invasiveness, it's just, you don't have to put extra line. And the advantage is that you know in real time exactly what the cardiac index of your patient and what the SpO2 is. And I will show you some example of why it's so important. Total intravenous anesthesia with the blood spectrum analysis. I showed you this. We use sufentanil, continuous sufentanil intravenous. In the valve surgery, we tend to place a small introducer in the right internal jugular vein in case you need it. In our early experience, we used to cannulate in each patient the femoral vein and the internal jugular vein. And with the new development of cannulas, double-stage cannula, I'm sure people will discuss that later, you don't really always need this venous drainage of the right upper jugular vein. But in case you need it, it's always important to have an access. So we ask anesthesiologists to place a small trocar, and therefore after this, if you have problem with drainage, it's very easy to insert a 17 French cannula into the jugular vein in order to have adequate drainage. Now, the position is very important of the patient. If you're going to do a mini incision on for the mitral valve, you have to position your patient with a roller pad behind the right chest in order to elevate about 30 degrees, and you have to have the arm a little bit below the plane of the table. Same thing if you're going to do a coronary, it's the opposite way. You position your patient with the left side a little bit elevated. As I showed here, you have to use femoral cannulation. Some people use direct arterial cannulation, aortic cannulation. You can do this through an incision also. It's possible with special cannula. I went over already the left internal jugular vein line, and we place a triple lumen on the left side for access. And this patient, as you can see, has double lumen cannulation. Okay, so let's go back into what happens when you give CO2 during beating heart surgery. Again, if you're going to go in, this is totally endoscopic surgery. There's no incision, meaning that you have a 12 millimeter trocar for the camera and two 5 millimeter trocar for the left and the right arm, and sometimes a fourth one if you need, but there's no escape of air. Why do we have to give CO2? In order to create a space for harvesting of the memory and to decrease the lung and place the lung outside of the field of operation. So what happens is that when you do this, you increase the gradient between arterial blood CO2 concentration and end-tidal CO2. So what happens, you artificially raise the CO2 concentration in the patient. So it's very important that your anesthesiologist decrease the CO2 that he's going to give to the patient. So you have to do more arterial blood gases than routine. That's number one. Number two, when you give CO2, you increase the pressure intrathoracic cavity, and therefore you reduce the venous return due to the intrathoracic pressure that is increased by the CO2 inflation, and also by the mechanical ventilation, because of course you have to continue mechanical ventilation either unilateral or, as I said earlier, with both lung and decreased tidal volume. So this is an example of a patient that we operate on. You see control before we do anything. He has, it's in French, I'm sorry, he has a heart rate of 77, a CVP pressure of 3, cardiac index of 1.5, a volume liter by minute of 7.3, inspiratory pressure of 19, good PO2, good PCO2, and good PVO2. Then you give CO2 for 30 minutes. Usually we give 8 liters per minute. And you can see what happens already. The CO2 rises, the heart rate increases, and look at what happens to the CVP. CVP is central venous pressure. It rises to 16, and the cardiac index is 0.7. But the mean arterial pressure, systolic arterial pressure decrease, but what's more important is the cardiac index. The volume stays the same because you have to keep the same volume measurement. The PO2 also decreased, have you seen, from 396 to 157. Why? Well, obviously because he's not exchanging as well, because your cardiac index is decreased. So what do? Well, the best thing is not to give inotrope, it's to to give some volume. So you give 500 cc's of plasma or whatever, and you can see that the CVP is the same because it's artificially augmented, but the cardiac index rises to almost normal level of 1.2. Or if it doesn't work or you have problem, then you have to reduce the CO2, meaning that you stop the CO2 and you let the CO2 outside of the patient, and you can see the CVP pressure goes down to 13, your pressure goes back up to 90, the CO2 pressure decreased to 8, and your cardiac index rises to almost 2 liters. But if you do this, sometimes you have problem visualizing the memory or during your anastomosis. So you have to find a compromise between not too much CO2, but and of course a good cardiac index. Then you increase the CO2 again, and you can see already that after 30 minutes that the CO2 pressure increased from 8 to 11. Your cardiac index goes down again to 0.8, and your CVP pressure increase immediately to 15. So you stop the CO2 and everything goes well. Why do I show this example? Because if you don't put a cardiac index monitor, you will not see all these changes. You will see basically an increased heart rate. You will see a little bit decrease in the blood pressure, but you say, okay, everything's fine, continue the operation, and actually your patient is not perfusing very well, and you will have problem even though you did the perfect operation with perfusion, and that can be very dangerous in anybody. So this is another example of what this arterial monitor gives you. Again, I'm not an anesthesiologist, but they explained to me that they have something called delta up, delta down, meaning it's the difference between the systolic and the diastolic pressure. I mean, it's the difference between during the ventilation, each beat systolic. And as you know, we're all cardiac surgeons, when the patient is what we call empty, there is a variation on the arterial curve. Well, this machine calculates it automatically, and it should not be more than 5%. This is what the goal is. If you have more than that, that means your patient is there's not enough volume in the patient. And you see what it looks like. So basically, if your delta down is more than 5 millimeter of pressure, it means your patient is hypovolemic. Sorry, and that means you probably have to preload and increase the preload. So again, this is at the end expiratory pause, and this machine calculates it for you directly. This is what it looks like on the monitor here. CVP pressure, temperature, CO2, and expired CO2, and of course arterial pressure. This is some of the literature in the Journal of Anesthesia that shows you that this predicting fluid responsiveness during cardiac surgery, and you can see that delta down is a very, very specific indicator. It's one of the most specific indicator, as you can see, compared to mean arterial pressure or central venous pressure, which is not a very good argument. Also, it can calculate for you the systolic volume and the diastolic volume. Okay, then let's go back to something else. Intraoperative myocardial ischemia. Again, you are doing your anastomosis. I will not explain all this because we have other speakers who will speak on this. So you detect EKG changes during the coronary clamping. Well, what do? You have to maintain good hemodynamic to optimize the coronary pressure. So again, you have this catheter. So ask your anesthesiologist to fluid volume the patient. Decrease the CO2 in order to increase the coronary perfusion. And you have to avoid tachycardia, of course, because otherwise it's very difficult to operate on a beating heart. So you give short-lasting beta blocker. And then if it continues this, then you have to use a small shunt. So you have to have a small shunt available. There are small shunt made by various companies, which are very easy to use, and even during robotic surgery you can use them. Actually, if you're familiar with them, it's sometimes easier to do the anastomosis over the shunt because then you are sure that your anastomosis is very wide. It avoids you to take the back wall of the memory. And so personally now I tend to use a shunt in almost every patient when I do a small beating heart operation. Now, post-op management. Most of these patients goes into the intensive care unit. Probably, I think it's some of these patients could go directly to the ward, but in our unit we have the similar management. We try to extubate them as soon as possible, sometimes on the table. Now, anesthesia is very, very important. When you do a sternotomy, the patient doesn't have much pain immediately. The pain comes more after. It's a discomfort. It's usually when he starts moving and everything. When you do this kind of operation, the patient has pain immediately after the operation, and then it kind of subsides within 48 hours. So you have to change your protocol. You have to use a continuous morphine drip that the patient can activate. And also what we do is we place a small intrapleural catheter which delivers continuous marcaine delivery for 48 hours. And really this changed, since we have done this, it changed the atelectasis, it changed the patient comfort, and he can really inspire and expire much better than if he has pain. So I think this is a very important issue that sometimes is not very well developed in our meetings. If you want, I have all the protocols for this and I can give it to you. So in conclusion, the anesthetic management requires minor changes, but these changes are very important. Selection of the patient is very important, excluding all previous thoracic and pulmonary diseases. Again, problem with CO2, so you have to be aware of this and how to fix it. And standard hemodynamic parameters should not be only assessed and should be analyzed with cautious because of ventricular preload. So again, I would encourage your anesthesiologist to place this continuous venous saturation monitor and arterial line monitor. Thank you very much, and I will answer